Yeah, so the recording started, and then so this is Social Epidemiology Lab, and this is one of our webinar series which we try to organize monthly with the help of our mentors who are experts, and they come to speak to us on different important research topics or things that are important as researchers in social epidemiology or public health, what we some essential skills that we can learn. So who are we? Social Epidemiology Lab is an international non-profit research organization with a dynamic team committed to untangling the complex interplay between social factors and health outcomes. So our young research team comprises of people with different backgrounds in sociology, medical science, data science, and we all share our experiences to investigate how different social determinants such as socioeconomic factors, race, gender, and community resources impact health disparities and disease distribution. So our aim is that our work will help to advocate for health equity, that everyone everywhere, no matter their societal or social status, can has access to the best quality of health outcome. So for this session, I will introduce our speaker, and she'll be talking to us on the policy impact and knowledge translation in social epidemiology. And we are very excited that Dr. Brittney Francis will be giving us this session. So Dr. Brittney Francis is a social epidemiologist whose research explores how different or how various interpersonal, institutional, and systemic factors such as structural racism and capitalism impact the development, the diagnosis, and management of maternal hypertension for Black women globally, which is one of the leading causes of maternal morbidity and mortality worldwide. Dr. Francis received her PhD in epidemiology from the Ohio State University, and she's also an alumnus of the Robert Wood Johnson Foundation Health Policy Research Scholar Program, and also completed a dual postdoctoral fellowship through the FXB Center for Health and Human Rights Structural Racial Justice Program and the Center for Population and Development Studies as a Bell Fellow, which are both part of the Harvard H. Kahn School of Public Health. She's currently a research scientist at the FXB Center and former president of Society for Analysis of African American Public Health Issues. So we are very happy to have you, Dr. Francis, to give us this presentation. And yeah, you can go now ahead to share your screen, and we are happy to learn from you. Thank you very much.
Thank you so much. I really appreciate it. Can you hear me? Am I echoing on your end?
We can hear you.
Okay. Okay, I feel like we have like a few people in the room. I feel like it would be helpful to me to hear maybe like quick introductions of like who folks are, where they are, and like what they work on. And I think it'll help me frame my conversation a little bit more. So if like folks can just like come off mute really quickly and introduce yourself, that would be helpful to me.
Yeah, please go ahead. Just unmute yourself and introduce yourself, please. No others, just, yeah.
Hello, everyone. Can you hear me?
Yeah.
Okay. My name is Shanika Butts. I am an assistant professor of public health at Davidson College in Davidson, North Carolina. My research focus is similar to yours, actually, in understanding how preventive care, specifically preconception health, can prevent maternal mortality among Black women, and also prevent pregnancy-related hypertensive disorders. So I consider myself to be a social epidemiologist and also focusing on life course perspective as well. So I'm excited to hear more about your work. Thank you.
Thanks.
Hello, everyone. Please just go ahead. No order, please. Just unmute yourself and introduce.
Hi, I don't know if you can hear me.
Yes, we can hear you.
All right. I'm Siri Ute. I'm currently working as a research assistant at Newcastle University here in the UK. and I'm focused on evidence synthesis. So my work and of course across different aspects of public health, but we are much more interested in synthesizing evidences and carrying out horizon scanning for drugs. So my focus might not be kind of in line with you directly, but our work kind of covers almost every aspect of public health. So what we do is to kind of carry out horizon scanning for medicines that are currently in development within phase 2, phase 3 clinical trials in specific countries, UK, US, Canada, Australia, and the EU, and then help to inform the regulatory authority within the UK to kind of fast track this new development to be brought into the UK to support patient care.
Thank you. I see Dr. Ahmed. Right here.
So Longundeng, can you introduce yourself, please? Looks like they are shy. So
Okay, no worries. All right, we'll get started, and if folks want to share as we go along, I just like to be able to know who's in the room so I can relate things to sort of like what you're doing, even if it's not necessarily in line with my particular research. So I'm going to go ahead and share my screen, and then I will get started. And then, as Jude said, if you have questions, feel free to put them in the chat. And I set aside 20 minutes so that we could have, sort of practical questions moving forward. All right. Okay. Okay. So the title of the presentation today is Scholar Activism, Policy Impact, and Knowledge Translation in Social Epidemiology. Jude did a great job introducing these, so I'm just going to go into the outline. So the three objectives for the session today were really will guide my presentation. So the first is discussing the role of social epidemiology in policymaking and what that sort of means to me. Thinking about effective science communication, and then providing some successful examples of knowledge sharing before we go into the Q&A. So I want to first talk about sort of my research agenda and how I think that situates within the policy frame. So my work particularly sits at the intersection of maternal child health, structural racism, health policy, and spatial epidemiology. And I really utilize mixed methods approaches to understanding how neighborhood level inequalities are shaped by anti-Black structural racism and how living in neighborhoods over the life course impact maternal complications, specifically maternal hypertension, so thinking about preeclampsia, gestational hypertension, those things, and how that changes globally, but also thinking about how that also significantly increases risk for cardiovascular disease later in life, which is also a leading cause of death for Black women globally. And a lot of the work that I do is situated and grounded in sort of these frameworks. I would say that I'm very invested in thinking about reproductive justice. So the human right to maintain personal bodily autonomy, the idea that women are able, or birthing people are able to have children, not have children, and if they do decide to have children, that they're able to parent those children in ways that feel safe and sustainable within community. A lot of my work is also grounded in the public health critical race praxis, which essentially is a framework that is adapted from the critical race theory, but within public health, to really think about how we situate both historical, cultural, and political context to understanding anti-racism research. A lot of work that I do is really grounded in environmental justice, particularly because I focus on segregation. I think a lot about what that means at a neighborhood level of who's exposed to certain things, who's not exposed to certain things. On a global level, what countries are exposed to certain environmental pollutants at the expense of other countries, and really thinking about the fair treatment, and meaningful involvement of all people, regardless of their race, national origin, income, with respect to the development, implementation, and enforcement of these environmental laws, regulations, and policies. And finally, as a scholar who is sort of trained in human rights theoretical frameworks and other things. I really think about what that means in terms of our fundamental rights and freedom and how we use that in terms of transnational solidarity. So I would say that there are three central questions to my research. The first is, how does societal distribution of resources, opportunities, and privileges based on racist ideology over the life course contribute to disparities in perinatal experiences, complication, and death among Black women globally? The second is, what policy changes can alleviate these inequitable health outcomes and combat the harms of anti-Black structural racism? And then finally, how can we translate information about the impact of racism on health to change our understandings of health disparities, to inform policy and disrupt sort of these narratives around the biologization of race and illness? And I would say I wanted to sort of ground that in my work because in the United States, we kind of see this narrative around Black maternal health. I think that it's gaining a lot of traction in terms of people understanding the disparities that exist. But with that, we also see this nuance and this development of politicians and other policymakers sort of inserting themselves in a way to make it seem like it's some sort of inherent sort of cause due to Black race, rather than examining the larger sort of like structural and social determinants that might be impacting maternal health for Black people domestically in the United States, but also the ways in which the US contributes largely to the destabilization of other things that might also lead to high rates of infant mortality in other parts of the world. And so I remember being at Harvard during my postdoc, and this particular senator came in to visit and was giving a talk and was invited to give this talk at the School of Public Health. And during this talk, he basically says that if we just remove all of the Black women from the counts, then Louisiana would no longer have a maternal health issue, and that it was solely sort of because of their race and their issue, and it was their problem, that they needed to figure out what was going on. And I will say that in that moment, I was sort of already trained in the health policy space and thinking about health policy, but I think it became very apparent to me the ways in which health is used as sort of a social and political pawn, and thinking about the role of us as social epidemiologists in sort of combating these narratives and how we can use that for real sort of political advocacy, and thinking about sort of scholarship as a tool for activism. So I think I asked the question that I think most people ask in science of like, so what does that mean? What do I do? How do I go about doing that? And I think the first thing that I sort of came to is the ways in which health is actually a meaningful way to engage in social and political conversations. One example that I think about, so there's a group at the FXB Center that focuses particularly on reparations and health, and how reparations could be used as sort of a meaningful way of thinking about health equity. And the frame of this health issue, rather than a wealth conversation, is something that we've seen that really is driving this conversation forward. So there's even a meeting going on next month between the African Union and CARICOM countries, and their conversations around reparation and wealth and what that looks like. And they're finally starting to introduce sort of this health into this conversation, right? What does that mean in sort of a colonial context? What does that mean in terms of what diseases and what sort of devices? I think I heard somebody say earlier, what development and what devices go to which country? How do we think about that in a perspective that really centers health and not necessarily other sort of social indicators? Because we know that they're linked, but we know health is a real issue that people can sort of navigate to. And as social epidemiologists, I think that we have sort of the upper hand in thinking about what that means to sort of frame those conversations. I also think about the role of social epidemiology sort of in policymaking during this time as really people who can understand the etiology of disease at a population level. So I think oftentimes we hear about, you know, just the broad social determinants of health framework and what that looks like and how that operates. But I think something that's unique to social epidemiology outside of just sort of the traditional epidemiology frame is really an investigation of how these social and political systems can contribute to the etiology of disease. So I think a lot about my own work and thinking about how stressors really have this really big impact on placental development, on the HPA axis, what that means for pregnancy, and how oftentimes we point to sort of like clinical care as ways to address the etiology of disease, when really as social epidemiologists, we can use our research to point to more population level and upstream factors that could be impacting sort of disease distribution as we know it. The other is thinking about development of interventions and policies that would be based on quantifiable data points. So I think something that is very unique in terms of epidemiology, and I'll tell you a story, is that we actually drive a lot of what the interventions are, right? I talk to my students a lot about us being like disease detectives. So we figure out who gets them, why they get them, how they get them. And when we can figure those things out, and as we actively figure those things out, we are actually at the forefront in collaborating with a lot of folks to develop interventions and policies because we have the data points. So prior to me going to get my PhD, I remember I graduated from my master's program, and I was working at sort of this, it was a consulting agency, and we were doing a lot for CDC and NIH and helping develop some of the campaigns and interventions that they were developing. And I would go into meetings and I would try to talk about racism. We were working with like a team at the Birth Defect Center. And I remember going in and wanting to talk about racism, wanting to talk about class, wanting to talk about these other things. And absolutely no one would listen to me. And I remember like going back to my desk one day, and one of the senior like study directors came by, and she was like, "Do you know why people don't listen to you?" And I was very confused, but yes, I want to know why. And she was like, "Because you don't have a PhD, because you don't have sort of this data to back up what you're saying." And I can tell you that day is the day that I started applying for epidemiology programs, because I saw very quickly that with data, you are able to shift a lot of the conversations because you have the quantifiable data points to be able to make the case for why we need to shift things in a certain way. And that helped me inform a lot of interventions and policies, I would say now in my work. But I think back to that experience often because I think epidemiology in itself holds a lot of power in terms of having those data points, developing those data points, and thinking through what that means. I also think that as a field, social epidemiology is a place very, very unique that I think it allows for a lot of transnational solidarity in terms of policy development. So last year I was invited to the World Congress of Epidemiology in South Africa to talk a lot about my work on segregation and what that means for housing and all of those things. And a lot of what I talked about were the relationships between segregation and apartheid and how that overlap really can help us think about how we develop policy, not only in the US, but how policies in the US translate to other contexts. And I think something like that is really important right now, especially because oftentimes we see that various nations, various states, various countries are used as exemplars for other policies in other countries. And so at some point we have to think about what that means in terms of policy development to be able to make equitable policy that, if translated to a different context, would still be equitable, obviously with some level of cultural nuance that would have to change, but thinking about the ways in which that would show up in sort of various geographical and social contexts. I think about that as very important right now, even in the case of seeing what's happening between South Africa and the US, and using apartheid as a way to be able to allow for immigrants to come to the US and what that means back and forth about the messaging of how that impacts health. I also think, and I want to sort of like harp on this point just a little bit more before I get into sort of the communication, the translation, is I think that social epidemiologists right now are more important than they probably have ever been. I think that a lot of what is happening in the United States is very indicative of the role of social epidemiologists, epidemiology in general, but I think a very specific subset of social epidemiology. One, because in the US right now, we're seeing a lot of deleted data, right? On the state level, on the federal level, data sets that were hosting a lot of these, what they're calling DEI efforts, but essentially health equity data, right? We're missing a lot now on gender. They've removed a lot on race. We've removed a lot on sexual orientation. We've removed a lot in climate change. Areas that really are sort of focused on the social and political context have been removed at the state and federal level. So what does that mean, and who bears the responsibility to then collect and store that data? And how are we communicating about that data when virtually decades of that data is now gone? I think the other part that becomes very interesting is the ways in which data can be manipulated. And as epidemiologists who understand statistics and understand other things like that, we, I think, have a role in really thinking about how we're engaging with data and how we're communicating about data in a context where we're seeing a lot of misinformation, we're seeing a lot of the data being manipulated to push certain policies forward. And I wouldn't just say that in the US, I think that's seen in a number of countries globally. And I think we have to start thinking about what that means in terms of how we're collecting data, right? Colleagues that I have, so me and my family are from Jamaica when we immigrated to the United States. And I think a lot about, they don't collect race data in Jamaica for multiple reasons, partly because they don't believe that racism exists in that context. And so a lot of what we understood about racialization and the data that I was working on with collaborators in Jamaica would come from the US. What happens when those data sets are deleted? What happens when that data has been manipulated? What role do we now play as social epidemiologists in doing primary data collection, storing that data, and having that data to be able to move that forward? I think we're also more important now than ever, because I think there's this large shift to sole sort of genetic causation of disease. I think it's something that I've been seeing quite a bit, where there's this idea that if a person is ill, it is due to some sort of genetic abnormality that is inherent either to them due to their race or their country of origin, or I could go on and on and on. But we're starting to see this big push. Back in March, all of the funding for my research actually was terminated by the government. And in that termination, a lot of the language was this idea that we don't know what we're talking about because diseases are caused by genetic abnormalities that are inherent to you, that are inherent to sort of racial groups, and talking about social and political things is really not real science, right? So what happens when we are now living in a landscape where we're moving away from sort of thinking about social causes and social and political sort of determinants of health, and now moving into a model where we see more precision medicine, and directly within that precision medicine, this idea of genetic causation of disease. And then I think the final thing is, you know, public health obviously is nuanced in the way that it's different from medicine, that we really focus on population health rather than individual health. But I think we're also starting to see this revert back to this idea, especially with the introduction of precision medicine, around this idea of individuals are responsible for their own health. Individuals are who cause, you know, health abnormalities, or people should be in charge of their health. And I think that there's a certain level that we have to start thinking about is, what is our role in policy making, but also what is our role in activism around some of these issues? And so I think like the shift in science communication, the shift in where we're going in social epidemiology is really having to interrogate how we're using our data, how we're collecting the data, how we're storing the data, how we're engaging with the data, and the stories that we're telling, right? So a lot of what I do is mixed methods, because I think that narratives are very important to help us understand sort of how data is playing out. But what role do we have currently in a landscape that is changing very, very quickly? So I want to switch a little bit to thinking about science communication. So I think traditionally, and probably everybody in this virtual space publishes a lot, right? I think in academia, we are taught that publications are currency, which I think is very true. The more you publish, the more you get out there, the more people will know you, you will get tenure, all of the different nuances that go along with why we need to publish, right? So we run these studies, we pay thousands of dollars to have these papers out there. And we do it in hopes that people will read them, people will use them in terms of advocacy. Community organizations that we might work with might be able to use them in sort of the efforts that they're doing. But really, I sort of push back on this idea, right? Like, these are papers that I've published throughout, you know, just in the last couple of years, but thinking about the amount of work and effort that went into these papers, drafting them, revising them, submitting them, revise and resubmit them. The journal tells me they want me to do all of these things. How are we thinking about what science communication looks like? So this is one excerpt from a qualitative paper that I have. And essentially in that paper, what I was examining was structural racism at the neighborhood level and how it impacts preeclampsia, but through this lens of interconnected systems. So this is one quote that sort of gets at that interconnected system that I'm calling the link between medical discrimination and community infrastructure and resources. And I'll read the quote for you, excuse me. When you go to a doctor's office and you feel like you're not important enough for them, it sets you on a downward spiral. And what happened was I started eating too much and then eating too much. And I like to eat salt. So there goes the hypertension. It wasn't a matter of just stress, it was what I was eating. And like I said, not having access to places like grocery stores, I had access to a bodega. I had $6 for a damn box of Lucky Charms, and I might not be able to get that cheaper with the EBT, which is food assistance in the United States. Go over there and get potato chips instead of actual potatoes, because he does not have potatoes, but he has potato chips. And if that's what I'm craving, that's what I'm going to eat, because guess what? That's what I can afford, because I don't have bus fare, but I have an EBT card. And so a large part of this conversation that came out of this interview was this idea that people are experiencing medical discrimination, and the coping mechanisms that they often have to engage with is eating. And eating can become a maladaptive coping pattern when you do not have access to grocery stores, when you do not have access to fresh foods. I think during pregnancy, people often eat and overeat as a stress and coping mechanism, because things that they might have utilized before, they might not be able to do, right? Their movement might be limited. They may have smoked, they may have done other sort of coping mechanisms, but we see that during pregnancy, eating becomes a coping mechanism often for a lot of people, and it becomes maladaptive when the food in your jurisdiction is not good, right? And so thinking about what that means in terms of medical discrimination, there's a lot in the US that talks about that, right? Addressing the bias in the medical or clinical setting, addressing all of these different things. But I wrote this paper with the angle that it's not just that we have to address the discrimination, we also have to address the community infrastructure and resources that happen when we're dealing with coping mechanisms of these experiences of discrimination. And so for this paper, at the time that I published it, there was a racial and equity and maternal health commission that was developed in Massachusetts, and they were taking testimonies. And so I remember getting all of the data from that paper and a few other papers that were looking at segregation over the life course. And I'm happy to talk about any of the intricacies of my work that you might want to know in the Q&A, and put all of this together to develop a testimony. And developed this testimony and went in front of the Maternal Health Commission, and only about 5 people heard my research. And then I went back and I looked at the paper and I was like, it's only been cited 5 or 6 times. I'm like, that's probably a total of 30 people, right, having read this paper and thinking about what it means for policy. And one, it's actually very difficult to develop testimony. I was lucky enough to be in the Health Policy Research Scholars Program through the Robert Wood Johnson Foundation during my doctoral training. And a lot of what they do is train us to do this, right? It's a very much of a learned skill, not to brag. But during my fellowship, I got best testimony and this mock testimony that we were doing, because what we were really trying to focus on is how do we blend epidemiology with storytelling? How do we figure out how to do that? And so I took a lot of those templates to be able to develop this testimony. Much of what my testimony about is how can we build neighborhood infrastructure with sort of dollars that we have at the state level that was allocated towards things like sidewalks, things like grocery store zoning, education, and so on. How do we build up that neighborhood level infrastructure to support health? It took me weeks to develop that testimony, to practice, to do all of these other kind of stuffs. And like I said, 5 people heard it, and quite literally, I don't think that it went anywhere. And so it led me to sort of thinking about this other sort of nuance around science communication. And I think that this is something that is really sort of undergoing significant changes as it relates to public health. Partly is because we're trying to adapt to a more dynamic and digital landscape, but also because there's more of a stronger emphasis on engaging with the public, utilizing diverse platforms, and then fostering trust and transparency through accountability. When you go back and you look at some of the papers, it's it's being engaged with other academics for them to be able to do more research. But what is sort of the reach and the engagement and the audience that it takes to actually move public policy forward? And in thinking about public policy, we have to center the public, because that is literally how you move policy forward and how you create organizing and activism spaces. So this graphic is from the Urban Institute. And something that I found interesting was it sort of outlines this level of complexity versus audience reach. And it shows that social media, out of all of these types of mediums, has sort of limited complexity in terms of development, but reaches a massive amount of people. Whereas more peer-reviewed journal articles take a lot of complexity and a lot of time and usually reaches less people. So I decided to do a little experiment. So I posted about neighborhoods and health and what at the neighborhood level impacts your health using results from that same paper. That one video got almost 60,000 views, almost 10,000 people engaged with it in terms of like liking it. There were over 100 comments of people asking to tell them more about what that means and ways that they can get involved in a public policy space. And then you can see people shared and save the video for later. That video was 16 seconds. And I think about how long it took me to write that paper versus a 16-second video and the reach. And so a lot of what I've been doing now in terms of thinking about science communication, in terms of thinking about what our role is as social epidemiologists in the public policy space, is utilizing different mediums and thinking about novel ways to engage in digital advocacy and public advocacy so that we can shift public opinion to how we think about public health, especially from a structural and social and political lens. So I want to share a few examples with you, and then happy to answer any questions. So largely, like if you're thinking about that graphic, this over, I would say, I guess like 2 years now, I've been able to utilize my channel, which is, my handle is at Dr. B. Fran on Instagram and TikTok, but utilize these channels to talk to people about various determinants of health. So we've been able to talk about things like education. We've been able to talk about things like mass incarceration, sexual and reproductive violence, intimate partner violence, thinking about homelessness, various topics, and really getting engagement of how that works so that people can understand what that means and what that looks like. There were a significant amount of challenges in doing this, particularly at the beginning of this year when we started to see a lot of this administration banning words, and those words then were being banned in the algorithm. It did become particularly difficult to do this, but we've sort of persisted in ways that we've had to utilize our creativity, right? So a lot of the videos that I was doing, I felt like I was talking about a lot of important things, and we would go to the comments and everybody would ask, oh my God, I love your outfit. Can you tell me what you're wearing? And so that has now translated into me doing this series called Public Health Outfits of the Day, where literally I give people a public health fact and then I tell them about the outfit that I'm wearing. And it's been something that is a really sort of non-traditional science way of communicating, but really being able to get that message out there. And so in about 2 years, I've been able to navigate, or at least gain about 7,000 followers, which I'm hoping to be able to grow that platform as I continue to do that a little bit more. In order to sort of like think about translation of longer form content, because TikTok and Instagram are usually like smaller videos and they're meant to be smaller videos, thinking about sort of translation and dissemination on longer form content, I also started a podcast called Higher Education with Dr. B. Fran. And essentially, depending on the topic, I either go and rant for about an hour on structural, political determinants of health and all of these different things, or I invite guests on to be able to share their expertise about a recent study that they've done in the frame of thinking about structural policy and how we sort of advance policy around that issue. So we've had topics, like I said, I mentioned before, around mass incarceration, homelessness, segregation, thinking about globalization of race and what that looks like, and situating it within a popular culture sort of like frame. So I remember the very first episode that I did was with a colleague from the UK, is at King's College London, and all of her work is thinking about colorism and what that means, and also various sort of racialization in different geographical contexts. And we use sort of the case study of Tyla, in the United States, with this idea of her being colored and how it has offended so many people, but thinking about how that translates into race and other contexts and how we can then think about that in public health. And it's actually been something that has been very engaged with. So we currently have listeners from South Africa, we have listeners from France, Switzerland, in a lot of these global contexts that then also want to contribute about how we think about public policy in their own spaces. So sort of going back to that transnational solidarity and collaboration. I've done episodes about Gaza and thinking about what the health harms are of genocide and how we think about that in a migratory sense, thinking about populations in South Sudan. And so we've been able to really sort of like collaborate with a lot of people to think about how structural and political determinants show up, but within a frame of pop culture, so that it makes it a little bit more easier for people to understand. It also led me to start a company called the Equity Collective. And through the Equity Collective, we essentially do a lot of like capacity building for public health organizations and community level organizations around what it means for like structural policy change as it relates to sort of health outcomes that are impacted by these things. And so I've worked with a lot of organizations of thinking about how to translate their own work or developing capacity building for the community level health workers to be able to engage more with people, to think about how they can sort of be political activists in their own space and help the public understand the role of social epidemiology and social factors in health development or health consequential development. Another thing that I did was develop an op-ed. And so in Florida, I think it was 2 years ago now, maybe 1 year or 2 years ago now, there was a bill called the Stop Woke Act, and it's now been signed into law. But essentially what that act says is that any person who teaches about structural racism or any of these things in a medical or public health K through 12, any university setting, if a student feels uncomfortable with any of that information, or if another faculty member feels uncomfortable with anything that's in that curriculum, they could then sue that faculty member. So I had a lot of colleagues who ended up leaving the state of Florida to go and teach in other places. But essentially what I wrote this op-ed about is this idea that if we remove that from curriculum, particularly in medical schools and public health schools, what will that mean for maternal mortality later down the line, right? And it was kind of salacious and it said all of these different things. But again, using hardcore epidemiology facts with sort of our sociological background and thinking about all of those things, coupled with storytelling to be able to make the point of how particular policies can impact health directly, even if health doesn't necessarily seem to be the focus of that policy. And so I think these translation efforts really sort of opened my eyes and sort of thinking about how we engage the public and what that means and how we help them understand what we do in order to shift public policy. So I want to share an example of a video with you really quickly. I think I can do this. Okay, so at the end of last year, so honestly, this idea came to me as I was standing at the bus stop, because I just saw a bunch of doves and pigeons outside, and I was really thinking about what does that have to do with sort of the socialization of race, and how do we help people understand the socialization of race when it comes to outside of the frame of what we think about the biologization of race. In March, there was an executive order in the United States that essentially said that anything that pointed to the socialization of race, rather than race being a biological concept, needed to either be removed from any CDC or NIH website, and also it needed to be taken down in all of the museums and the Smithsonian. And so it really became important to me to think about how do we help people understand what that looks like. And so this is what I had come up with. Please tell me if you can see it.
Yes, we can.
Okay, let me play it. Hi, my name is Dr. Brittney Francis, and I'm going to explain the socialization of race to you in less than 2 minutes. What do you think of when you hear me say pigeon? I'm not going to lie. They're a little dirty. They run in packs in the inner city, and they wait for random strangers to drop them food. Alternatively, what do you think of when you hear me say a dove? Some would say pure and religious. Some might even think of a wedding or a special occasion that they've been to where those doves have been released. But what if I told you that they are the same? Doves and pigeons are in fact the same species, but we as a society have socialized the meaning around these birds purely because one is all white or that the other one has color. When you think about doves in the wild, it's very rare because to maintain that sleek body and that pure white color, they're often bred with one another. While in the wild, you'll see various types of pigeons because the melanin production is usually based off the environmental pollutants that are in the air, with higher melanin protecting them from these risks. Starting to hear a little pattern? How is it that we assign value, worthiness, and resources based off the production of melanin? When you think about it in that way, we can transfer that logic over to humans. If we continue to think about the ways in which biological differences show up, we don't think about the social construction. So if there is no biological difference, but only the social values that we apply, it's easy to see how, depending on where you live or how things are classified, race is a social construct. So the next time that you're thinking about race, I want you to remember me. And I want you to remember, because doves are pigeons too. Okay. So that particular video actually got a lot of feedback from students. I've had faculty members say that they now show that in their class to be able to help people understand the socialization of race. But again, a lot of that is due to years of research that needed to be condensed down into sort of smaller bite-sized pieces of information. And I think as social epidemiologists, we have to figure out ways to be more creative and sort of moving that forward in ways that the public can understand. Because I think a large part of policy development, a large part of political change is really engaging the public. And I think often scientists have really sort of been sitting in this ivory tower of thinking that we're communicating with each other and things will change, but we have to figure out a way to engage community at a community level in ways that they understand so that we can all sort of collectively empower one another to be able to move public policy forward. I will say one thing before I sort of wrap up about this, and I want to be transparent in that with this major shift in what I would classify as science communication and thinking about effective communication, thinking about policy development and how it's sort of outside the realm of our lab and papers, is that there are very real safety concerns. Since I started doing the TikTok, I've received death threats. Colleagues of mine that have written op-eds have received mail from like detention facilities of people that have said all of the horrendous things that they would do to them, both in terms of like sexual violence and domestic violence, because of their engagement. And I don't think that it's unique, right, to any particular place. I think we see that when you begin addressing social and political issues, there are real harms that come, whether it's from a governmental level or from a population level. There are things that you have to think about in terms of like your safety. I mentioned earlier that the Trump administration had banned a lot of the words, right, that are related to equity. Here in the US, we can't say women, we can't say community, we can't say differences, which is like a key part of thinking about epidemiology, right? We're constantly measuring differences between various demographics. We can't say any of those words in sort of like how we're communicating in official documents, right? And many of the universities are in fact engaging with this, right, and requiring that their faculty members abide by this. What happens in that landscape when now our papers are being censored, and what does science communication look like when the political sort of administration doesn't want us to talk about the truth of what that looks like in terms of the health landscape? There's also been a lot of suppression of content that has come with my TikTok. So a lot I've been getting banned and said things about community guidelines when talking about public health and the dismantling of the infrastructure, but other larger social epidemiology things. And then also just the general sort of like news outlets, right? So that one op-ed that I wrote about Florida and Ron DeSantis somehow ended up on Fox News, and the amount of letters that I received at my job was actually quite alarming. Especially as a single person, right, and thinking about what that means in terms of my own safety. And so if folks are thinking about engaging with that, I do have sort of recommendations that I would make about safety concerns to be able to make yourself feel more safe in terms of the courage to be able to engage with some of that. And so I just think that at this moment, we as social epidemiologists are sort of nuanced in a way that we can have multiple conversations with multiple people. I think we can have a conversation with the political scientists and the sociology group because we understand the landscape of social, structural, political determinants of health. And then I also think we're able to have conversations with health folks because we understand the etiology of disease. And I think right now is probably an opportunity where we can really stand in the gap of thinking about what knowledge translation looks like for both of those audiences and become more engaged in sort of thinking about policy development. So I will stop there, and I will take any questions, comments, concerns.
Yeah, thanks very much, Dr. Brittney. Has been a very wonderful presentation. I hope our attendees also felt the same like me. Yeah, I think you've delved into a lot of different things, and yeah, with the changing dynamics of our world today, social media, different political landscapes, I think science communication is something that is also is shifting a lot. And yeah, like you said, we have to find new ways of communicating science in the best way that those who are really important, those who really need to benefit from this, learn from it. So we have one question in the chat that we will ask I think Sally Tabe asked, and her question is, how do we get more youths to understand the role of epidemiologists and see their importance in contributing to policies? So that was her question.
Yeah, I think first things first, we have to tell them what we do, right? And I know this may sound crazy, but we have to make it look cool. I think in a landscape where people are choosing careers or thinking about different things based on what is cool or what is right, I think we have to show the parts that are engaging. Something that has come up on social media, again, like talking about the outfits or talking about traveling or talking about going to conferences. A lot of what I see from like my younger audience is them like saying like, oh, wow, you do that as a social epidemiologist. And it's like, yeah, it's pretty cool. Like, it's pretty cool to go to these places and talk about policy. It's really cool to be engaging in that way. And I think like we have to allow ourselves to be more involved in the work, right? I think especially in PhD programs, I think we're often trained to be like these objective scientists, but science is not objective, and therefore we are not objective in the ways that we show up. So I think the ways in which we personally show up, I think our cultural backgrounds and the ways that show up, a lot of what I talk about on TikTok is using frames, right, of being Jamaican and what that looks like in a landscape in the United States. And I feel like it opens the conversation to be able to have some more of those conversations, because people are realizing, yes, it's a very sort of serious level career, but it also has elements for which they're looking for in other careers. And then they're realizing that they can make incredible change by doing it. So I would say, sort of summing that up, one, we have to tell them what it is. We have to tell them what social epidemiology is. And then I think we have to make it look cool.
Yeah, thank you, Doc. Sally, hope that answered your question. So yeah, go ahead, Dr. Shanika, please.
Thank you so much, Brittney, for that presentation. Question about your the opportunity you had to testify in front of the commission. You said 5 people heard it and you don't think anything came of it. What was the makeup of the body? Like, I'm not familiar with this body of representatives, like who was there? And I know how you got a chance, you mentioned how you got the opportunity to do it, but who were the individuals that heard your testimony?
So they were various senators from different committees. So the bill that was on the floor was, during the Biden administration, there was an infrastructure bill. And the infrastructure bill was supposed to essentially like talk about neighborhood level infrastructure and how that could improve things for the community. So these were people from like energy and different, I guess, committees. That's right, like that, different committees. But nobody was really talking about health. And so the frame that I was bringing in is that, like, yes, like all of this that we're talking about is cool, but we also need sidewalks, because in my research study, I'm finding that pregnant people will get interventions from their clinical staff that they need to go and walk. Where are they going to walk? In the street? Like, that's not going to work. And so that was like a lot of like what my testimony was about. But the committee itself were senators that were not necessarily invested in health. They were not necessarily invested in that way, but this was now a committee that was focused on maternal health and thinking about how to use some of that infrastructure money to address sort of this cross collaboration of maternal health in their jurisdictions.
Okay, thank you so much.
Mm-hmm.
Yeah, thank you, Doctor. So I have one question. So most of our attendees here are from the Global South. So I want to just, maybe it's a question that they have in mind also, like how do, we have a lot of issues. Of course, it's coming up in the US now, but in the Global South, a lot of political issues, instability and things like that. So, and also, of course, issues of inequality. So how do these factors, like these power dynamics, how do they kind of affect whose knowledge or whose opinions or whose research or things like that gets translated into policy? Are there any specific things that the researchers can do, like to lobby, or I don't know, like how does it work? Like you can do a very good research, like, I mean, you've already navigated that part. How can you advise young researchers what can you advise them to do?
Yeah, I think that's a great question, but also a very hard question for me to answer. Partly because, like I mentioned, I think in a lot of countries, like we're seeing that prop up in the United States, but like to your point, in the Global South, in the Caribbean, and Latin American countries, we've already seen sort of this power dynamic where if you speak out against certain things, there are very real dangers that could happen, right? I think doing it in collaboration with people strengthens that, because it makes it less about sort of one singular person and more about sort of a collaborative effort against sort of an issue. So something that I do in that realm is I partner a lot with community organizations that are already doing policy work. So I think about one thing, when they were building new prisons and thinking about prisons, there was a community group that was already sort of doing the on the ground work. And I just went to them and asked them, what data do you need? They sort of told me, and then I went back and I pulled the data. And so I think that's a meaningful way, if a person doesn't sort of want to be on the forefront of that, to engage skills that would be really meaningful in terms of like that power dynamic. I think in terms of whose knowledge gets to be shared, I think this is an issue that we're probably going to continue to face, right? In terms of journals, what journals are accepting, from what countries are they accepting, what impact factors do certain journals have? I think it's something that we as sort of a field might need to grapple with a little bit more. I don't know that I necessarily have an answer, but I think in terms of knowledge production and knowledge sharing, I think we're already seeing that from certain places. Like I even think, again, going back to my own work and my own family and colleagues that I have in Jamaica, we don't even have a public health journal on the island. Trying to get work published from Jamaica is extremely, extremely difficult. One, because we don't have a journal. And then the second is when you try to publish in American journals, the costs to be able to publish in those journals are so high that the research budgets simply can't afford it. Something that I've done, right, is giving money, like being able to use my US-based grants to cover costs for articles that might have happened in various countries, because I know that that necessarily is not the case. So I think, like, again, figuring out ways to partner with people with money, that's just the real, partner with people with money, partner with people that are already doing some of this work, and figure out how your skill set can be meaningful, right? Like I often think about power structures as like this power over, power within model. And I think, like, for the most part, we have to just figure out what we bring to the table. As social epidemiologists, we have data. That's something that we hold, and we have the power to be able to do that. So we can contribute that in a very meaningful way. And if we're in community and collaborating with other people, I think it becomes easier. I would say all the way though, on the other end of that is, I think something that is really good about social media, that to me is a benefit of shifting away from these traditional like peer-reviewed publications, is anybody can get on the internet and say something. So what may have traditionally been a barrier to you getting knowledge out there could partly be removed by engaging in more public spaces, because you get to reach people directly. People may not be able to access or pay however much money it costs to get behind a paywall to get a paper, but I guarantee you a lot of people have Instagram and TikTok on their phone. A lot of people have Twitter on their phone. So if you remove even that barrier of how we're communicating with people, right? Because again, we write articles, and if you don't pay that crazy fee, people have to pay to download the article, which means it's limited in terms of how that article is being used. If you're utilizing something like social media, it costs nothing to put your research out there. It costs absolutely nothing to be able to have people globally engage with that work. And I think because of that, we reduce some of the things in terms of that knowledge gap of who gets to put information out there and who gets to be an expert. Because again, now you're directly communicating rather than waiting for people to read your paper.
Oh, thanks a lot, Doc. And that was my following question was around the topic of miscommunication, because I wanted to understand, like, since we have social media now, a lot of information is out there. So, like, how can we, like, researchers be able to build trust with communities and decision makers? Like, because sometimes, yeah, maybe what we are trying to say is probably they don't even trust it or they don't believe it. So, but how can we, and I think you already answered some of it, maybe you have something to add to that, like how can we as researchers build trust with the communities and decision makers that are actually involved in this policies translation or things like that?
My answer will always be if you involve them. Like, I don't do anything without community partners. Yeah. And I find that to be a value of my work, because if they're involved, there is already an inherent sort of like trust relationship. Now, it does take a long time to build those relationships. In terms of the community partners that I worked with, this was me going to someone's house to bake, me going to people, right? Like me going to toy drives, me doing all of these things to actively be engaged with community to build trust. And I think that's something that we as social epidemiologists should be doing in our research anyway. I think as it relates to communication, if you already are engaged with community and you have trust, people are likely to trust community partners over researchers. I'll give an example of Harvard, especially here in Boston. No one trusts Harvard. They find out you work at Harvard and they're like, no, we do not trust that institution. But I work with a lot of community partners. So it's less about Brittney from Harvard and more about, oh, that was Brittney that I met last week at this thing. Oh, okay, I can listen to her now. And I think figuring out a way to sort of find the balance between institutional sort of reputation and your own community trust, I think is probably the balance that we need to think about a little bit more in terms of communicating with the public. And again, involving them in ways that they can also communicate on our behalf. So because the way that I set up my studies are a lot of my community partners are considered co-researchers, they can also communicate about these studies in ways that I can't, because they're in community very differently than I am.
Nice, thanks, Doc. Does anyone have a question? If you do, can you please raise up your hand and ask? We still have enough time for questions. If you do, just ask. If not, I will ask my final question. So my question is, looking at the emerging situation, or since social epidemiology is an emerging field, and what do you think, or what are the most potential real-world changes that can come from social epidemiology? Like, what, since it's an emerging field, which areas can you really maybe encourage young social epidemiologists to dive into that will really create or have a real impact in our world? Or communities, maybe like in the global south or diaspora?
Yeah, I think issues around reproductive justice and gender-based violence is something that I think is very, very needed in social epidemiology, especially as it relates to reproductive and gynecological issues, other sexual and reproductive health issues, both for all gender, sex, whatever. I think that that's a really big issue. I think the intersections of like capitalism, multinational corporations, and climate change, I think will be very, very vital moving forward. And then I also think like the ways in which artificial intelligence is currently being used and the algorithms that go into that and how that impacts health, I think will probably be the next wave of like social epidemiology, of thinking about how the development of these technologies include or exclude people, how the development of these technologies create undue environmental burdens based on where they're building data centers. I think social epidemiology would really have a place in that.
Cool. Thanks a lot, Doctor. Is there anyone with another question? So if not, then I think we've had a very wonderful evening with Dr. Francis, and yeah, again, we are really happy to have you speak to us this evening, and yeah, taking out the time from your busy schedule. I'm sure we all learned a lot of good stuff here, which will help us as we grow in this field. So those of you who joined late, if you want to have a certificate of attendance for this session, please you send us an email to socialepidemiolab@gmail.com. And then I will also, Dr. Francis will share with us this presentation, which later on I can send an email out with this presentation, and also a link to the video recording, which you can watch, rewatch when you have time. So we have these sessions happening monthly, so stay tuned to our social media channels. You have an update on the next session, which will be taking place next month. So yeah, with that said, we want to thank all of you who joined us for this wonderful session, and we thank very much again Dr. Francis. She's, just to note, she's one of our mentors of the Social Epidemiology Lab, and yeah, a lot of good stuff will be coming out from Social Epidemiology Lab because of her presence there. So stay tuned to that, and yeah, we thank you very much, and yeah, look forward to seeing you in the next session. Thank you very much.
Thank you, Jude, for putting this together.
Yeah.
Thank you, everyone.